Okay, so hello everybody and welcome to the ESDR Kitchen. I'm Eli Sprecher. I'm from the Department of Dermatology at the Tel Aviv Medical Center in Israel, and on behalf of the board and my co-chair, Professor Curdin Conrad, I'd like to welcome you all to this new sweet and sour episode of the ESDR Kitchen. I'd like to remind you that the ESDR Kitchen program, as well as previous episodes, are all available on the ESDR website. And as you must know by now, I guess the sweet and sour episodes are usually delivered by two leaders in their field who discuss a very controversial, hot, spicy topic. So today we are particularly pleased to welcome two internationally recognized outstanding scientists, Professor Sonja Ständer and Professor Gil Yosipovitch. So first of all, a few words of introduction on our two speakers of today. Sonja Ständer is Professor of Dermatology and Neurodermatology at the University of Münster and the head of the Interdisciplinary Center for Chronic Pruritus, KCP, at the University Hospital of Münster. She is board certified in dermatology, in allergology, in phlebology, and in dermatopathology. Shortly after completing her habilitation, she established the Interdisciplinary Center for Chronic Pruritus and played a leading role in the foundation of the first international and national societies for itch. In 2011, Professor Ständer obtained the title of Professor of Dermatology at the University of Münster and dedicated herself to translational neurodermatology and pruritus research, becoming a worldwide leader in this field. The University of Wrocław in Poland awarded her with a Doctor Honoris Causa title in 2015 for her research efforts. And now to Gil. Gil Yosipovitch is a tenured professor and Stephen Endowed Chair of Medical Dermatology at the Dr. Philip Frost Department of Dermatology at the Miller School of Medicine at University of Miami. He is director of the Miami Itch Center, which focuses on chronic itch as a disease state. Before joining the faculty at the University of Miami, Dr. Yosipovitch was founding chair of the Department of Dermatology at Temple University and directed there the first translational clinical and research center dedicated to the study of chronic itch in the US. He has published more than 500 articles in books and peer-reviewed journals, has edited 5 books. He is the founder and past president of the International Forum for the Study of Itch and member of its board. He served as chairman of the scientific board of the National Eczema Association and is member of the scientific board of the National Psoriasis Foundation. He serves on the editorial boards of 6 key specialty journals. He is the recipient of the most prestigious Marion Sulzberger Lectureship Award from the AAD. He has given more than 500 invited lectures, so I guess that this one is the 501 to different dermatology groups and organizations around the world, and he has mentored more than 40 fellows, PhD students, and postdoc fellows. And now, just before handing it over to our two debaters, I'd like to remind you that we will have at the end of the session a Q&A session, and you are more than welcome to forward your queries through the chat and the Q&A functions. Sonja and Gil, thank you on behalf of all of us for the opportunity to hear you today. We all feel quite itchy in anticipation of your talks, so please, the floor is yours.
Yeah, thank you very much. Welcome on behalf of Gil. So first we have some general slides prepared for you. So today it's sweet and sour, but you see it will be a little bit spicy in between, and we are happy to discuss with you at the end. Of course, every one of us knows itch. Itch is a very important function of the skin for self-protection, as is pain, and it helps us to eliminate toxic plants and other things that do not belong to the skin surface. But here we discuss now the chronic state as a state of a disease, chronic pruritus defined by the duration of 6 weeks or longer. And here we can understand it as a danger signal of the skin or inner organs that some disease is evolving or existing. So chronic pruritus is a very frequent problem. We know it globally. We know it's in every age present. And so it's no wonder that the Global Burden of Disease Project put it under the top 50 most burdenful diseases worldwide of all interdisciplinary diseases. And it ranges among the top 15 skin diseases. So, of course, we know it in dermatology. We see it every day in dry skin or atopic dermatitis, but we find chronic pruritus also in more rare diseases such as bullous pemphigoid. And here we see that it's also present outside dermatology, such as in internal med, in neurology, and even in psychiatry. We find patients who have chronic pruritus and, of course, also skin involvement. So that's the topic for today. We know that itch is induced by environmental factors, endogenous, cutaneous, and extracutaneous factors. We know that this leads to the perception of the signal in the brain, and Gil will go into this direction. And then it comes to scratching, and we have skin damage and skin alterations, and I will comment on this. With that, I like to hand over to Gil now.
Yeah. So thank you, Sonja, my esteemed colleague and friend, for the introduction. And thank you, Ellie, and the ESDR team for instigating today an argument with my colleague. And my point today would be that the brain is a major target for treatment of itch. So first of all, why target the brain? So I believe that all of us understand that the skin is where itch is emanating, but the brain is the terminal that receives all the input and also could be the place where itch could be suppressed because if you look at this figure, the itch comes from the skin, it's transferred by the nerve fibers, but it goes all the way up to the brain. And what happens is that there are a lot of factors involved in itch that are part of the chronic itch condition, such as psychological factors, stress, depression, anxiety, neuronal factors. And if we could target these areas in the brain, we could reduce the scratching that is also has a significant component in the brain. And I'm not undermining the dermatological treatments, but I believe that this is a treatments that target the brain could be beyond just one disease. One of the common things in patients with chronic itch is a phenomenon that you see in your patients called neural sensitization. And this is it's a heightened sensitivity to stimuli that may occur normally in the peripheral and in the central nervous system. This is an example of patients that I'm sure you see in your clinic. These are the miserable patient. This is a patient who has the butterfly sign, has prurigo nodularis, and she complains that actually if you touch her skin, it becomes more itchy and more burning and painful. And this is neural hypersensitization. And the neural hypersensitization has a significant component in the brain, which I'll argue later on. But I mentioned that causes of neural sensitizations are multiple. It also relates to other aspects of CNS and brain, such as insomnia, because the lack of sleep aggravates that. There's also an imbalance of neuropeptides in the brain, including upregulation of mu opioids and kappa opioids, downregulation. I mentioned before already psychological stress, and also some neuroadrenergic descending system changes and alteration. And also inflammatory components could affect the brain. And in this figure, we show that neurosensitization is also in the periphery, also in the spinal cord, but has a significant impact in the brain. And this is a study we did with functional brain MRI. And what you could see is in patients with atopic dermatitis, when they received an itchy stimuli, areas that are known to be centers of neurosensitization, but also in pain, such as anterior cingulate cortex, the insula, the putamen are highly activated versus healthy subjects that receive a similar itch induction. And now going into therapies that targeting the brain. So many of the treatments that you are using nowadays, such as GABAergic drugs, drugs such as SNRI, mirtazapine, and also kappa opioids and also NK1 inhibitors that my colleague Dr. Ständer had contributed significantly, work on brain pathways. Let's start a bit with mu and kappa opioids. They are known to have an imbalance in chronic itch. Patients with chronic itch have overexpression of an opioidic system of mu opioids, where there is also downregulation of kappa opioids. There's an argument here that it could be a peripheral effect, but we have shown that actually that there is a significant effect on the brain. So this is a study where we looked at the effect of butorphanol, which is a kappa opioid and a mu antagonist, on brain activation of itch. And what we found was that there was a significant inhibition of histaminergic itch by butorphanol. It totally eliminated it, and it paralleled activation of areas in the brain, such as the nucleus accumbens and septal nuclei, suggesting that these areas can inhibit itch. In addition, when we process the itch in the brain, and many patients with chronic itch always complain that they feel bad with it, that it affects also their mood. And part of it is that they perceive more severe itch sometimes than they actually have. And this is related to catastrophizing, and it relates also to changes in brain rewiring system. So this is something that is also common very much in chronic pain patients. And in fact, when we looked at changes in patients, this is a resting fMRI, meaning we did not induce itch in these patients. These were patients, and we've seen that area that is involved, it's part of a default network. It's an area where is activated when we do not have external stimuli, is highly associated with itch ratings. Again, suggesting that the brain has here a role in the chronicity of the itch and the perception of itch. In addition, amygdala is an area in the brain that you may remember from neuroanatomy in medical school, and it's highly associated with stress and anxiety. And indeed, that area is highly associated with itch activation. So all these activations in the brain suggest that the brain is a valid target for treatments of itch. And another interesting phenomena that you sometimes experience, especially when you see a scabies patient, is that you feel also that you're starting to itch. And this is a phenomena also related to brain activation, is when we see someone itchy, we feel more itchy ourselves. And we've looked at that in patients with chronic itch, in particular, and patients with atopic eczema. And indeed, we showed that we induced with saline in atopic eczema and told them that we're giving them an itchy stimuli and showed them pictures of people scratching versus non-scratching. The patient, when they saw the pictures, had a significant itch perception. This happens also in healthy, as you can see here, but it's not so robust like in patients. And in addition, we had a video camera installed on the computer so we could follow them. That was before the area of Zoom. But as you can see here, they started scratching beyond the areas where they had the eczema, significantly more than healthy subjects. Again, suggesting that the brain has a significant impact on our chronic itch and therefore is a great valid place for treatments. And indeed, we wanted to explore where in the brain this phenomena occurs. And with our colleague, Dr. Christina Schutt, who's a psychologist who came to work with us, we brain imaged this phenomena. And again, have shown that the areas in the midbrain, these are the striatum, this is an area that is highly associated also with scratching, is highly activated when patients see other patients scratching. Interestingly, this area is not activated in contagious itch in healthy subjects, suggesting that this is, again, a unique area in patients with chronic itch. So to conclude my argument is that brain regions associated with itch and the urge to scratch are known now. And by reducing neural activity in these brain regions, we could alter the vicious cycle of itch and scratch. And drugs that target the brain may reduce chronic itch more potently than those in periphery. So, Sonja, now it's your turn to argue for the periphery.
It will be hard to fight against that, but I will try to convince you that the skin is also very important in itch induction, and yeah, so also in the effects mediated by scratching. So when we take a look at the pathophysiology of itch and some reviews, for example, here this very nice review from Langan and Weidinger, you see that we have, of course, a lot of music in the skin, and that we have, for example, the epidermis that is involved in the itch induction, of course, not only by the keratinocytes with their many functions, but also what they release, for example, NGF that promotes growth of nerve fibers, or semaphorin 3A that stop nerve fibers. So we have direct communications here with the intraepidermal nerves, and maybe also with the Schwann cells that might be important in itch. So they are demonstrated to be important in pain assessment. So there's no reason to believe why they are not in itch. And of course, we have in the dermis, we have all these cells which are weaponed with a lot of interleukins, neutrophins, and pruritogens in general, and even histamine plays a role in itch induction. So the keratinocytes, and that's very interesting, they are not just forming the barrier, they detect a lot of environmental changes up to that they can sense olfactory sensation, and they are also discussed to maintain and enforce itch signals. They can even potent electrical currents. And of course, when we scratch, they sense a mechanical stimulus, and this changes also the metabolism of the keratinocytes. Then we have the nerve fibers in the skin. And here you see how many neuroreceptors they express, which are relevant for itch induction. Starting here with histamine part 2, we have the huge group of the mass-related gene protein-coupled receptors. We have bile acid receptors. We have this interleukin receptors. And as you see here, most of them generate action potentials via the TRPV1 receptor. So here it is now spicy, the heat receptor, and a cold receptor, TRPA1. So of course, this raises the question, which nerve fibers do we have in the skin? And we know that we have, of course, depending on the current velocity, C fibers are delta fibers. These are the quick ones. The C fibers are the slow ones. We can define them by the expression of the receptors. For example, we know that 5% of these nerve fibers express histamine receptors. And more modern animal studies, mouse studies, say that here we have more subclasses of non-peptidergic fibers, which also transmit itch signals. This is not validated yet for humans, but we know we have different classes, and it seems that all classes participate in itch generation and transmission. And the question is, how behave these nerve fibers in the chronic itch state? And what we know is that there's an alteration of the neuroanatomy. And this was first demonstrated by Gil in lichen simplex, for example, but also by others, as in this example for prurigo. And we were very surprised to see that the nerve fibers are reduced and not increased in number, but they are all reduced. And this is demonstrated here. And it was shown also for other entities. And this is a work by our group. Here you see we took skin biopsies from lignified and non-lignified skin versus non-pruritic, non-lignified skin. And all these intraepidermal nerve fiber densities, they are reduced. So when we take a closer look at the intraepidermal branching behavior of the nerve fibers, you can see that in chronic pruritic entities, the nerve fibers are all more branched, and the more the skin is lignified, the more branching you can see in the nerve fibers. So we have alteration of the neuroanatomy in pruritus, but is more enhanced in those states where we have heavy scratching. And that it's due to scratching shows this paper, which demonstrated that the nerve fiber density normalized more or less in non-lesional, non-pruritic skin after a therapy of these patients. So, but what about the function of the nerve fibers? And as Gil stated, we have neuronal sensitization, but can be peripheral or in the central nervous system. Here we use the paradigm to test it, and applying courage induces hypernesis in patients who have this neuronal sensitization. Again, here demonstrated for prurigo, but it's confirmed also in other entities. Here again, we have atopic dermatitis and brachioradial pruritus, and it's always, you can always see here higher itch intensities in patients, either in lignified or in non-lignified skin who have chronic pruritus states. Interestingly, we see differences between these two entities where we assume that itch is induced in the skin in the atopic dermatitis, and in brachioradial it's induced outside the skin. And you see, for example, here that these patients with brachioradial pruritus have more burning sensations. And now we can very good argue, are these the skin nociceptors or is it brain enhancement here? And the same was demonstrated for electrical induced itch, also type of inducing hypernesis or showing hypernesis in patients with chronic pruritus. And here really we saw a difference that in lignified skin of atopic dermatitis, we see enhanced signal compared to brachioradial pruritus where it was vice versa. So it seems that it is relevant, the periphery is relevant if either we have itch induction in the periphery or we don't have it. We have it outside, and maybe the signal is just enhanced due to the altered skin anatomy. Yeah, as I said, we have brachioradial pruritus where we have the origin of the pruritus outside the skin. We have compression at the spinal cord level, and it seemed that then there is a altered function of also the peripheral nerves and reduced expression of TRPV1, for example, in the skin, what was demonstrated in one paper. And interestingly, though, we have here the origin of the pruritus outside the skin, we can treat the patients with topical capsaicin, and they have a long-term reduction of itch even for 1 year when we use a topical capsaicin patch. And before treatment, they have reduced TRPV1 expression that normalize after the therapy. So this is a good argument that we can treat chronic pruritus even if the origin is outside the skin with the topical peripheral therapy. And as Gil said, the opioid receptors are of high interest, of course, those in the spinal cord level, those in the brain, but we also have them in the skin, as demonstrated here in 2 studies. This is a paper from Jacek Ciepiatowski's group, and he could demonstrate that those kappa opioids receptors are reduced in those patients which have hemodialysis-related pruritus, chronic kidney disease associated pruritus nowadays called, and they are itchy versus those who don't have itch. And interestingly, in these patients, a peripheral kappa opioid receptor agonist, diphenylkephalin, is very effective. And it's said that this receptor acts in the periphery and not in the central nervous system. So another argument that treating the peripheral nervous system is effective. And so to summarize here, of course, we have primary but also secondary involvement of the skin in itch induction and maintenance. Scratching is a very important factor. Scratching seems to change the neuroanatomy and also the neuronal function. And yeah, I'm convinced peripheral therapies might reduce itch, but many questions remain open, such as how do astronauts scratch an itch? But maybe we are happy to discuss this and other questions with you now. Thank you.
Thank you much for the two of you to this excellent discussion, excellent talks. We don't have any questions so far. I'm actually having one myself. You mentioned mainly the origin of itch and how to treat it, but not so much the quality of itch and the perception. What about that? Is that more peripheral, only peripheral? Is this also central?
Yeah, this is one slide. I hide it because I thought I would not have time enough, but there are some studies around that, for example, patients who have a warm sensation along with itchy behave differently and had different receptor expressions than patients who have neuropathic sensations such as burning. And those with warm sensation have interestingly increased TRPV1 receptor expression compared to those with neuropathic sensation which have a lower TRPV4 expression in the epidermis. So there are some translational findings pointing to differences in the skin expression level and functional and structural changes. Yeah, so this also seems to be located in the periphery. But there are not many studies. Gil, what do you say?
Oh, yeah, my comment is, yeah, it all comes from the brain, the perception. So clearly, yeah, there's a lot of components. Just to let you know, I mean, this I didn't present, but patients with chronic itch, this we didn't publish some of it, reluctant, but in the spirit of sharing everything, is that we noted that the gray matter in the brain of patients with chronic itch is significantly reduced. Again, suggesting that the brain has a real big effect on it's bidirectional. I'm not arguing that there are changes in the periphery that cause that, but it was interesting that after treatments, the gray matter increased. So the brain has plasticity to respond in chronic itch. And I think this is an area that will be very exciting in the future. So stay tuned.
Also for therapeutics, I think that's going to be easier to address there. We have one question in the chat from Benjamin Hidalgo. There is a Korean paper that topical acetaminophen gel 5% works on cow-H and non-cow-H induced itch. So what would be the mechanism of action there?
Well, that's my paper, but that's against my argument because it's a topical effect.
See, Gil?
You got me on that. But yeah. I'll tell you what is interesting, and the mechanism is really, no one knows how acetaminophen works. You know, it's funny, this is 70 years we know this oral medication. By the way, oral doesn't work for itch, except really it doesn't have any effect. But the topical, we think, has an effect on phospholipase. And Sonja showed phospholipases are highly associated with signaling in the itch pathway in the periphery. So we suspect this is the mechanism, but we don't know actually.
Gil, does it work on the sodium channels?
Interesting. I don't know. That I don't know.
I also don't know.
We thought that it works on cannabinoid. That's a hot topic again to discuss, but I'm not sure because acetaminophen apparently orally has some effect on cannabinoid receptors, but we were not able to show that. So I don't mind if I don't know the mechanism as long as it works.
We don't have any questions for Eli. Do you have any additional question?
Maybe something that I've been asking myself for a long time. When you speak about pruritus, whether it is central or peripheral, you always think about something which is mediated by some part of the nervous system. But what about itch as a sensation conveyed through mediators and not by the nerves themselves? So is this something which in terms of the contribution to the sensation of itch is significant, not significant, and how does that translate into therapeutic interventions?
Yeah, that's a really good question, and here again we really don't know. We don't understand a lot, for example, from the chronic kidney disease associated pruritus, and also lymphoma associated pruritus. There you think the neoplastic cells might release some substances, but always we come to the point to argue, okay, there's a release even when the cells are in the skin and they bind to the nerve fibers. So we really don't know the exact mechanisms of non-neuronal induced itching. And I guess this was your question. So Gil, I mean, aquagenic pruritus, what is that? Yeah, so what is going on there in the skin? Also, no one knows.
So, Ellie, it's an excellent question. I believe, and Sonja, I think, showed very nicely in that figure, that keratinocytes are neurosensors too. So they have the same receptors for nerves that, including, opioids, NGF, you name it, and they come from the neuroectoderm too. So I won't be surprised that you could signal even with a keratinocyte a sensation of some sort that is itchy. But I have to also point out that now we know that all the cytokine receptors are in the DRG, in the nerve. So there is a lot of interactions there. So we can't just isolate and say, well, there's just one factor involved. So there's a kind of cocktail, and everything is a bit more complex than just a simple receptor.
Thank you.
Off topic, but a good comment from Benjamin again. In AD, also children try to control their parents' behavior towards them through scratching. So it's also a coping mechanism. And I think that's another starting point for each scratch itch cycle in that regard. That actually the coping mechanism that starts and each scratch cycle.
Yeah. And I mean, there are a lot of psychological effects around itching. It's annoying, and especially when you have it in a chronic state, the patients, almost every patient, have kind of anxiety, is stressful, even up to depression, and these are all the psychic factor which may in addition worsen and maintain the itching. So this is really very, very complex. And when patients come to our center, and Gil also published a lot around that, the first that they want to share is their burden and the quality of life impairment, the sleep loss, and so on.
Yeah, I mean, there is also physiology with the psychology. So we tend to think, oh, it's just psychological aspects, but it involves neuropeptides, it involves serotonin and stress, and all this connectivity in the brain is very much associated with it. To the point, if you do, it's interesting, if you induce in an experimental model in patients with eczema, and we've done that, we induce itch and we do an acute stress test. We test them on, they count numbers from downwards, like 1,000 to 997. It's not so easy to do. And then we ask them to give a talk on their pros and cons on their personality. We've shown actually that their itch we were expecting their itch to be higher, but apparently it has a paradoxical acute stress. And also it's interesting, their autonomic nervous system is acting weird. It's almost like a neuropathy. So we looked at their, it's called heart rate variability, and they have a damage that is equivalent to patients who have fibromyalgia and also diabetic neuropathy. So there are a lot of interesting factors involving in the neural system that involve autonomic nervous system, and stress. And I'm quite sure that later on, I wish, these are studies that are not so well funded because we don't know exactly receptors involved, but they're very interesting in terms of physiology and psychology. Do you agree, Sonja? I mean,
yeah, and the interesting part of your study, Gil, was really that the patient reported that they have less intensive itch, but that they scratch more. Yeah, and here you see we have the effect of the response to the itch with this mechanical stress onto the skin is also a huge factor, and also that has finally psychological aspects when the patients see that they scratch until they bleed and so on. That's really a problem. And I guess that this is also referring to Bernard's question. He says, is psychological stress-induced itch central or peripheral? So, Gil, what do you think?
Well, Bernard has an excellent question as always.
Yeah, as always.
But
Hi, Bernard.
I'm a big proponent of the brain, but I have to tell you, Bernard, the barrier stress, psychological stress has an effect on even skin barriers. So clearly there is some peripheral effect, but I say it's top down. It's the hormones from up doing the damage in the periphery.
Sonja, anything to add?
I totally agree.
Okay. So with that, I really agree with Bernard Holmes' first phrase, great talks. Really, thanks a lot for this absolutely amazing discussion and amazing talks. A topic which becomes more and more relevant and appreciated also, I think, which was a huge, or is still a huge burden for patients. And luckily have you guys and others who work on that topic. Just a brief announcement before we skip on, move on. Obviously, the talks will be again available through the website and YouTube in a few days. The next one, ESDR Kitchen, will be in 2 weeks. 2 weeks, yes. On Lars Norland will be on the skin barriers. And just a reminder, you have another 4 or 5 weeks for the abstract submission for this year's ESDR at the annual meeting, which will be face-to-face in Amsterdam in September. And an announcement from the ESDR again is the Solidarity and Adversity initiative, which was recently launched by the ESDR. We obviously support any support which has been done towards the people suffering from this situation, the war. We have established an option to send supplies, in particular medical supplies, to the area through a short channel. So this will be really used the way it should be used. So if you have anything, and here is a list of what is urgently needed, if you have in your department or anywhere else the supplies that you can ship, you can find the contacts here or otherwise through the ESDR website. And with that, I'd like to thank the 2 speakers for their talks, and Eli, obviously, for the excellent sharing, and all of you for listening, and see you soon. Thanks a lot. Bye-bye.